Hello, hi, it's Dr. David Janarious back with another episode of the After Hours Clinic podcast. Today, I am following up on a topic we had broached upon in an earlier episode. Specifically, we're going to be looking at the topic of cholesterol, statins, and what the evidence really tells us. In a previous episode, we had talked about some of the claims from Dr. Peter Attia, who's obviously come under scrutiny given his less than savory connections with Jeffrey Epstein. And, upon these revelations, of course, there's a lot of people out there that are sort of putting his whole career into question, right? Because if someone's unreliable in one area, obviously you wonder if they're unreliable in others. So one of the things I thought it'd be important to do is just kind of look at some of his claims and talk about whether they actually are pseudoscience or, kind of misinformation. And one of the big claims he makes in a lot of his podcasts and in his books is the idea that we should be looking at treating cardiovascular disease from a 30-year perspective. So, currently guidelines recommend considering cholesterol lowering medications, namely statins, when someone has a risk, an elevated risk of having cardiovascular disease in the next 10 years. So, again, the current guidelines, they are not really looking necessarily at really long-term risk, right? They're kind of trying to identify people that are more at risk in the near to intermediate future. So he kind of posits that, hey, maybe we should be addressing long-term risk by getting people started on these cholesterol lowering medications instead of 10 years before they're at risk, 30 years before they're at risk. So obviously that would mean a lot more prescriptions of statins, which is a really controversial topic. I think statins are one of those medications that have kind of have ridden the wave when it comes to popularity and notoriety. So when they first came out, in the 80s or 90s, they were sort of seen as a miracle drug, right? Because they can substantially lower cholesterol, which has been shown to lower your risk of having heart attack or death related from heart attack. And obviously, this is a huge value in a country like the US, where the number one cause of premature death in US adults is heart disease. And so with that promise came millions upon millions of prescriptions. And in fact, the most commonly prescribed medication in the US is a statin. It's atorvastatin or Lipitor. And with that wave of popularity has kind of come a lot of criticism of statins, particularly that they're overprescribed, that they're kind of treating something that's a symptom of disease as opposed to treating the underlying disease, and that, quite possibly that they are doing more harm than good. And this idea that perhaps we should be looking into statins more critically has come up from a number of sources. I think some of it can definitely be attributable to the increase in popularity of health influencers and podcast health influencers, particularly like your podcast bros, I think are the ones that are really sort of shining the light on statins and kind of pointing out the idea that maybe there's more to the story. And I think just culturally, there's kind of been a moment where there is this sort of decline in the trust we have in a lot of institutions, particularly in medicine. And, pharmaceutical companies, I think, are kind of a deserved target of that scrutiny, right? Because pharmaceutical companies at their worst do a lot of harm, and they oftentimes will do that harm by misleading. So for example, they may suppress certain results that suggest harm. We saw that with the medication Vioxx, where, which was used as like an anti-arthritis medication, was found to cause an increased risk of like heart attacks and strokes. Obviously, there's so many documentaries on the misleading data regarding the OxyContin and the opioid crisis. There are medications that get approval that in reality don't have much evidence to prove that they're much better than just taking a placebo. So there's all kinds of trickery. So I think when people are dubious of the claims of pharmaceutical companies, I think they're right to be so. And I think it's smart to ask a question like, hey, are we over treating with statins, or is it quite the opposite? Should we actually be treating more aggressively? So I kind of want to break down what we know about this topic. So one topic that I think that patients ask me a lot, that I've gotten over and over and over again, is like, what is the link between cholesterol and heart disease? Because there's all kinds of information out there, and a lot of it does seem to contradict each other. So I've had a number of patients, and particularly in the fitness bro space, that have been turned on to the idea that it's actually low cholesterol that's harming people. It's actually low cholesterol that's putting people at risk for heart disease, whereas actually increasing cholesterol is protective against the heart. And there's so many people in the space that say some kind of variation on this. I know Joe Rogan is a particularly I guess the word maybe is aggressive of the pharmaceutical industry. I know that Paul Saladino, with his ridiculous carnivore diet, has stated that that the link between cholesterol and heart disease is misunderstood. And there's, I'm sure, a whole number of other influencers that are kind of pointing to this idea that we may be misunderstanding the link between cholesterol and heart disease, and in fact it may be completely on its head. And so I think that's a claim that deserves a little bit of investigation in and of itself. So we were talking about the relationship between cholesterol and heart disease. So I think a little bit of definitions are in order here, just to make the conversation more clear. When we talk about the link between cholesterol and heart disease, I think it's worth kind of talking about a few of the terms that we use in talking about cholesterol. So two big terms that that are mentioned in this graph we're looking at here. One is LDL and the other is ApoB. What LDL is? LDL is what people colloquially call the bad cholesterol. And this is sort of a measure of how much of cholesterol is actually found in the cholesterol packets that are floating around the bloodstream that lead to the formation of plaque in the vessels. So it's actually kind of a measure of concentration of cholesterol. ApoB is actually a what's called a lipoprotein. It's a marker that's found on all of the plaque-forming cholesterol particles that are found in the blood. So ApoB is actually a better marker of the number of potentially plaque-forming cholesterol particles that are found in the blood. And both of these have this kind of association in medicine, that they are known to be correlated with heart disease, meaning the idea that in treating heart cholesterol is that we are actually lowering both ApoB and LDL, with the idea that we are going to prevent the progression and buildup of plaque in the arteries around the heart, and thus prevent like heart attacks and premature death. But interestingly, a lot of the data that I think people are citing when they're talking about this inverse relationship between cholesterol is actually data that is taken for observational studies. So in other words, in these kind of studies, what they'll do is they will take a large population of adults, and they will measure their cholesterol, and then they will follow them going forward to see, based on their cholesterol level at baseline, how likely is it that you will go on to develop a heart attack or death from heart-related issues. And they are then trying to link a correlation between LDL or ApoB levels in your risk of later on going on to develop one of these undesirable events like heart attacks or heart failure or that kind of thing. And interestingly, if we look at these graphs, so on the top two graphs are looking at the relationship between ApoB and on the left, all cause mortality, meaning death from any cause, and on the right, death from heart related issues. And what we see is at the very low ends for both all cause death and death from heart related issues, we see your risk of, of, of developing one of these two conditions actually increases with lower levels of ApoB, and actually decreases as we go up in concentration of ApoB. And there is sort of this sweet spot right here at around 100 to 120 where your risk tends to be lowest. So again, this sort of seemingly flies in the face of the idea that there's this link between cholesterol and heart disease. If we look at the graphs just below them, these are actually looking at the relationship between LDL and heart disease. And again, at the low levels of LDL, we're seeing increased risk of heart disease. And as we move across, actually with LDL, we see that as we increase LDL concentrations, the risk of heart disease or death from any cause drops. So again, what this seems to be showing us is actually as cholesterol goes up, we are decreasing our risk of premature death. And it seems to be the relationship that goes up as we increase testosterone. Meaning, if we look at this graph in and of itself, there doesn't seem to be like a ceiling to that threshold. And again, this is sort of the complete opposite of what most people are being told by their doctors, right? That most people are told by their doctors, we need to put you on a statin to lower your LDL in order to prevent a heart attack. But this observational data is actually showing, hey, the people in a population of adults, it's actually those who have high LDL that seem to have heart attacks less. And so in looking at this, it calls into question, is everything that we know and that we've been told conventionally about the link between cholesterol and heart disease completely wrong? Well, not exactly. This actually brings up an important topic when we talk about using statistics, inferring things from medical literature. Is that you have to kind of understand what a study is telling you and what its limitation. This is like a major pitfall, and this is where I think a lot of people can easily be manipulated by health influencers, particularly those selling things, is because if taken out of context, a study can tell you something that's the complete opposite of reality. You can draw conclusions from studies that aren't there at all. So in this kind of study, what it's telling us is a correlation. There's telling us there's this correlation in a population study that at high levels of cholesterol, we're seeing less death. At lower levels, we're seeing more death. Well, we don't know that it's actually low cholesterol causing more death, right? It could very well be that there is something associated with having low cholesterol that is causing more death. For example, certain types of cancers will cause really low cholesterol levels. So if you're looking at a large population of people, you may be capturing people who disproportionately have illness in the very low cholesterol ranges of that population, right? So that may be telling you you may be extracting a relationship that doesn't exist. What actually may be happening is it's actually illness that's causing premature death and not low cholesterol levels. And again, at the higher levels of cholesterol, you can also get other kinds of false associations. And furthermore, and in this particular study that was done in 2025, when they're looking at this relationship between cholesterol and heart disease, they're looking at one measure in time. So they measure them at baseline and they follow them forward. We don't know if later some of these people in the high cholesterol group were automatically selected to then later receive statins. We may not have all that data, and so that may obscure some of the relationship. Um, this is sort of a classic logic fallacy we run into a lot when we're looking at interpreting medical literature and medical data. This mistaking correlation for causation. There's a really classic example that occurred in the 80s and 90s where there was observational data that showed that people with the highest levels of consumption of beta carotene and highest levels of beta carotene in their bloodstream, they tended to have lower incidence of lung cancer. Again, there's this correlation between high levels of beta carotene and low lung cancer. Obviously, the next question is there causation? When they actually tried to look at trials where they supplemented people with beta carotene who are at high risk for lung cancer, they didn't see a decrease in their risk of lung cancer. In fact, they saw a slight increase in their risk. And again, that is because observational data that is correlative. It can be that relationship can be obscured by another relationship. So, for example, in the case of beta carotene and lung cancer, while people who consume more foods with beta carotene are likely to have a healthy user bias, meaning they are the people that are less likely to smoke. They're almost certainly, even if you try to control for their exposure, they're almost certainly going to have lower cumulative exposure to smoke over time than age-matched control. So so to better answer these questions, there are studies where they try to look at populations to get a more causative analysis. And these are what are called Mendelian randomization studies. And Mendelian randomization studies, what they do is they look for genes that are responsible for an exposure of interest. In this case, either ApoB or LDL, and they look for their distribution in a population, and they make the assumption that people with more of the causative genes are going to have a higher level of both either ApoB or LDL. Because there is a genetic association. So the idea is if you look at the genes as they're distributed in population, they'll be distributed randomly because most people, unless there's a lot of inbreeding, genes are distributed to a population randomly, and those genes will be expressed over the course of a lifetime. So as opposed to it being just a single measure in time and you follow them forward, you're going to get that exposure interest over the course of a lifetime. Also, you are not going to necessarily get that reverse kind of causation. It kind of helps tease apart correlation from causation because, for example, I gave the example of people who have certain kinds of cancer may have low levels of LDL when checked at the end of their life. But cancer is not going to affect the expression of the ApoB or the LDL gene. That's going to be constant over time. So when they look at the actual association between people's the genetic expression of either ApoB or LDL and their risk of then developing heart disease, the relationship looks a lot different. This graph actually looks at that relationship. So top left, we're looking at the relationship between heart disease and ApoB, and it's essentially a straight line. So as we go lower, we have less heart disease. As we go higher, more heart disease. This to its right it's also just the relationship between ApoB and death from all causes. And again, it's a flatter line, meaning it's slower changes with increase in concentrations. But again, it's still a line. At lower concentration, we see less all-cause death. At at lower concentration of ApoB, we see lower all-cause mortality. At higher concentrations of ApoB, we see more all-cause mortality. And again, this kind of study is, I think, gives you much more of an idea of what's causally happened as opposed to a correlation. And the reason in addition to it just being a much more elegant design, the reason I trust this data over the observational relationship that shows an inverse relationship between cholesterol levels and heart disease is the fact that it jives very well with the data we have looking at cholesterol lowering medications and heart disease, right? So if we look at, all the trials on statins and heart disease, what we find is that there is, again, this association with lower levels of LDL and ApoB, putting you at lower risk for heart disease. Another way of thinking of it in terms of number, for every 40-point reduction in LDL, there's about a 20% reduction in your risk of it developing a major heart-related event like a heart attack. And in terms of like the spectrum, in terms of like, do we see a point at which perhaps lowering cholesterol is undesirable, meaning a point at which heart disease deaths increase or adverse events actually start to increase? We can actually look at the data from some of the newer class of medications that actually have lowered people's cholesterol to levels that were far lower than what we were traditionally achieving with statin medications. So this class of medications, they're called PCSK9 inhibitors, and they are injectable medications that have a completely different mechanism than statins. And these medications were studied in people who, for example, weren't able to get to their cholesterol goals on a statin. They would add these medications in addition, and they would hit just rock bottom levels of cholesterol. And we're talking about LDLs of in the 20s and 30s. So this particular graph was taken from one such study. And again, this is looking at the risk of major adverse cardiovascular event, or MACE, as it pertains to the LDL concentrations. And again, we're kind of seeing the same graph that we saw with the Mendelian randomization, meaning as we go lower on LDL, we see your risk of heart disease drop, right? There does seem to be a point really, at the very lowest point here, about 23, where perhaps we see a slight increase in risk of heart disease. But again, at numbers so low, it's hard to know what to make of that data, just because there's so few people who are going to be in ranges that low. But again, what we do see is, for all intents and purposes, as LDL increases, your risk of heart disease actually goes up. And interestingly, in these kind of these trials with these newer medications, we're not seeing like a huge uptick in any other significant adverse events. Meaning, one of the concerns with really low cholesterol is, increased risk of like bleeding inside the brain from like ruptured blood vessels or aneurysms. Those weren't demonstrated in the trials where they were really dropping people's cholesterol low with pharmaceutical intervention, which obviously is super reassuring. Now, the question as to whether we are perhaps understating the risks of statins, or perhaps that has not been, it's been undersold to the public. I think that is worth, kind of investigating. When we talk about risk of statins, I think overall, I will say just up front that I think statins are actually one of the most well tolerated medications out there. Serious, like life threatening or life altering side effects are very rare with statins. Most clinicians will see a handful in their entire career. Those big ones are going to be something called rhabdomyolysis, where statins can actually cause a rapid breakdown of muscle. In rare cases, that can be life threatening. And then there are very rare reports of acute liver failure. Again, people will probably see serious cases of either of these a handful of their times in their career. They're far less than 1% of patients that would be on the medication. The absolute numbers in a large population, while they're not I would never say trivial. They are far less than the benefit that we extract from them. There are some questions that I think are worth investigating in terms of like long-term muscle side effects. So although we don't commonly see acute life-threatening muscle damage, there is some data to suggest that perhaps there's some low-grade muscle injury that's happening in the background over time that may not even be perceptible. What impact that may have in the long term on muscular strength, frailty, that kind of thing, I think definitely is something that needs to be investigated further. The kind of preliminary data we have, it doesn't seem to have a very large impact on long-term muscle health, but I think certainly worth investigating further. But in the case of muscle health, absolutely the prevention that you get from preventing heart attacks is far more than, the potential risk of muscle disease. I think the biggest risk to most people and the biggest real risk that I see on a pretty regular basis with patients is the increased risk of diabetes. So, depending on the trial you look at, there can be, per year, about a 20 to 30% increase in the risk of developing diabetes in statin users versus non-users. And that risk is cumulative, meaning the longer you spend on a statin, the more that risk goes up. So if you've been on it for a decade, for example, you may have twofold the risk of developing diabetes than someone who would not have been on. Someone, who is the same age who is not on that medication for a decade. I think it is still worth pointing out that when you look at the absolute number, you're going to prevent 5 times as many heart attacks than you are going to convert into diabetics. So still, it's a 5-fold kind of difference in terms of benefit in terms of preventing heart disease than risk of creating new diabetics. So again, the benefit's still in favor, but that is a real risk that we see with statins. That risk goes up if at baseline if you're in that pre-diabetes range or have insulin resistance. But that being said, when it comes to even in diabetics, the number one cause of premature death in diabetics is heart disease. Still, while that is a real thing, and I think we should be talking to our patients more about that real risk, again, from an overall prevention standpoint, we're still going to be, still going to benefit being on statins. Also, in patients that do start to veer toward diabetic range when they're started on statin, there are medications that do not have that risk. So some of the newer classes of cholesterol medications don't necessarily have that same risk, and you can use those medications in place depending on their insurance coverage. What else when it comes to diabetes? Yeah, I mean, we can kind of identify the people are at highest risk, the people who are pre-diabetic. Those are also people you may want to consider, the use of GLP-1s, particularly if they're overweight, to prevent that conversion. That's another strategy. So in addition to other meds, pairing with the GLP-1s, which a lot of people are doing anyways, because they're trying to get that weight loss benefit, that may pair well because you also get a reduction in your risk of heart disease with GLP-1s. So, kind of compounding benefits there. What else I think is important to mention regarding diabetes side effects? I don't want to forget anything. Yeah, I mean, I think we talked about, identifying people are at risk, what we can do to prevent people from going on to developing diabetes, and, potentially using other medications. Now, the last kind of thing we want to talk about is are statins overprescribed? You know, I think there's, particularly in the kind of population in America that is MAHA adjacent, right? The ones who embrace the keto diet and carnivore diets and want to get rid of dyes and question vaccines. A lot of people will point to the kind of evils of big pharma and call into question, pharma on a lot of things, which I think they should. But let's hone in specifically on this question. Is this something where pharma is deceiving us? Is there perhaps a financial motive to keep us on these medications and keep us sick? And are we giving out too many of these medications? Well, I want to look at it in a couple ways. When it comes to the money and the financial incentive pharma, the one thing about statins, they've all been generic since 2021, and the vast majority have been generic since 2016. So right now, a lot of statins can be obtained without insurance for like $4. For example, atorvastatin, the most commonly prescribed one, absolutely can be obtained cheap. So there's not a huge financial motive. So are we prescribing it to too many people? Well, in one sense, perhaps, right? Because if you think about it, most people who get on a statin are not going to have a heart attack in 10 years or even 30 years. Just like most people who get a colonoscopy are not going to need it in terms of they're not going to go on to develop colon cancer. So there absolutely are going to be millions of people that are on these medications that if we had never put them on the medication may not have needed them. But I just want to do a real quick thought experiment. Just like we have kind of determined that it's worthwhile to screen everyone with a colonoscopy after the age of 45 because data shows that it reduces the risk of dying from colon cancer. Imagine we did a scenario where we just put basically all adults starting at, let's say, 25 on a statin, and we drop their cholesterol to rock bottom levels, and we follow them forward going for 30 years. Well, in 30 years, would we have more diabetics? Would there perhaps be some people that reach frailty sooner than others? Possibly. But on the flip side, what I can tell you is almost certainly we would not be having a scenario where heart disease is the number one cause of death amongst American adults. I think we would completely see a complete sea change in what's causing premature death and morbidity in adults. So in a sense, yes, they may be overprescribed, but in another sense, we're probably not reaching all the people who could be benefiting. And because again, we're looking at risk from a 10-year perspective and not necessarily from a 30-year perspective. So, in summary, yes, I think we have ample evidence to show that there is a link between cholesterol and heart disease. I think there is ample evidence to show that by lowering these numbers, we can prevent that outcome. There is ample evidence that shows that statins are effective at reducing cholesterol and in preventing heart disease, and that the risk ultimately does outweigh the benefits in the vast majority of cases. And that there's also, in this field, there's newer treatments out there, and not to mention so many that are on the horizon, that this is something that one way or another, you should really be looking at modifying your risk if you're at all at risk for developing heart disease, which is like most adults. So I think, again, I hope this kind of sort of puts the truth of this really complicated subject sort of out there in front, and sort of helps it put it in perspective with all the kind of conflicting data you may or may not have heard out there. I really hope you found this valuable. If there's other topics, please reach out to us if you'd like a specific topic to be addressed when it comes to health, longevity, politics, whatever it is. I love fielding patient questions. This topic in itself came from a patient questions. Without you guys, I don't have interesting things to talk about. So I had a really good time going through this with you. I hope you found it informative and entertaining, and I look forward to doing it again in the near future.